Hi, this is Mrs. Lewicki, and I'm going to talk to you about bowel elimination, constipation, and impaction. This is set up more as a concept map, but I'll talk to you about each thing. So, constipation can be a primary problem or a manifestation due to another problem. Acute constipation is often caused by an organic process, such as anatomical concerns, neuromuscular concerns, or endocrine changes. Chronic constipation persists or becomes more frequent, and constipation can lead to incontinence and issues at night. So, constipation is when you're having fewer than 3 bowel movements per week or a difficulty in passing stool. I already talked about the pathophysiology. I didn't say that also that psychological or behavioral concerns can cause constipation. Also, straining at stool can lead to further complications for patients with heart disease. Risk factors for constipation include low activity, immobility, irregular toileting habits, changes in routine, privacy concerns, chronic use of laxatives. So, clients that have eating disorders are at risk for constipation because they chronically use laxative. Irritable bowel syndrome, muscle damage, and neurological conditions. Prevention is diet high in fiber and fluid, increasing activity, fiber supplements, and stool softeners. Clinical manifestations include infrequent bowel movements, abdominal discomfort, decreased appetite, straining at stool again, and hard, dry stools. Collaboration, we're looking at diagnostics. DRE is a digital rectal exam, and digital means your finger. And it depends on the situation whether or not the nurse is the one performing it. Barium enemas, colonoscopies. I don't have on here just a flat plate x-ray of the abdomen can also contribute to a diagnosis of constipation. Medications we would give would be laxatives and cathartic preparations. Non-pharmacologic includes education, which includes, ambulation, frequent ambulation movement. Nutrition, which includes increasing fiber, increasing water intake, and behavioral changes, behavioral management rather, bowel training, biofeedback, and we may have to digitally or manually remove stool. Lifespan concerns are children and adolescents should have been reviewed in pediatrics. Pregnant women often will have a mechanical problem because as the baby gets bigger, it pushes on the bowel, and so that increases the likelihood of constipation. Increased progesterone and iron supplements also contribute. And older adults it's affected and more frequent in older adults because of laxative use, because of dietary changes as you age. A impaction is a mass of hardened stool in the folds of the rectum or colon. It's a prolonged retention and accumulation of fecal material. And what you'll see in the patient with an impaction is they'll have skid marks on the sheets and on their underwear. They may have liquid, foul-smelling material with no formed stool. They start to feel full and feel ill. They get abdominal distension and possible nausea and vomiting. We'll do a digital exam, and what we'll feel is hard, impacted stool, and abdominal x-ray, caused by poor habits, laxative dependence, and possibly barium if they've had a barium study in the past few days. Treated with administration of cleansing enemas or may need to be manually removed. So you might have to go in and pull out that stool. It should be done gently and carefully, and it is within the nursing scope of practice, but hospital policies can vary on that. Incontinence is the involuntary leakage of stool. There's several causes for that. It can be impaired function of the anal sphincter. It can be partial or a major blowout. Emotional it's emotionally distressing to be incontinent. It can be physiologic or psychologic. So anal sphincter or nerve damage can be caused by neuromuscular diseases, spinal cord injury, and tumors. Risk factors: spinal cord injury, nerve damage, diabetes, and can be age-related. And other risk factors are dementia, and physical disability. Can be prevented by preventing constipation, increase physical activity, increase fiber and fluid in the diets, treat diarrhea, and avoid straining. Clinical manifestation is the loss of voluntary control of bowels. Collaboration diagnostics would be the history and exam, an anorectal manometry, rectal motility test, sigmoidoscopy and barium enema, CT scan, and cognitive health exam. Surgery could be done to repair a rectal prolapse if that would be the cause. Meds are antidiarrheal meds and antibiotics. And non-pharmacologic is diet, again, fiber and water. Teaching Kegel exercises, biofeedback, and skincare is important with incontinence because having the acids from the stool sitting on the skin could cause skin breakdown. Lifespan for children and adolescents, it should have been reviewed in pediatric. Pregnant women, again, we worry about that baby getting bigger and pushing on the bowel, pushing on the anal sphincter. And older adults have incontinence more frequently because of loss of sphincter tone. And so the last blank page is for you to complete a a concept map on bowel elimination.